Welcome friends, welcome students and my dear colleagues to MuniMeterHealth, your site and source for learning cardiology and the human heart. So welcome again to MuniMeterHealth. I'm Dr. Jaitly, your cardiologist from New York. Without any further ado, like I always say, on every segment we come up with a new subject, a new topic, and today we'll be very briefly talking about what should be an echo examination entailing when you're interrogating aortic stenosis. In other words, when you suspect a case of aortic stenosis referred to you by an internist, what should an echo examination entail or perform for? So you're looking at one LV ejection fraction. Okay, it's very important. Normally it should be more than 50% or 55% depending upon the labs. So 50% and above should be a normal ejection fraction. In aortic stenosis, actually it's even hyperdynamic. It could be 75 or it's normally a hyperdynamic. So that's abnormal, but again, ejection fractions over a period of time, they drop in aortic stenosis, and that's a very, very negative prognostic indicator of survival. So again, more than 50% ejection fraction is good actually, but less than 50% will not be good. LVH, you look at the left ventricular hypertrophy, and normally it is a concentric variety of hypertrophy. Here I'm drawing the ventricle here, not so classical eccentric here, but the very fact is that this is concentric in that it has a hypertrophy of similar nature throughout in all the walls. And eccentric variety is normally present in mixed lesions and in hypertension cases. You look at this ejection fraction, as I said, and you also look at the left ventricular end diastolic volumes, and then you look at the left ventricular end systolic volumes, and if you subtract this will give you the stroke volume. Okay, that is the stroke volume. And stroke volume, if you divide that with left ventricular end diastolic volume, will give you the ejection fraction. Okay, so that's your ejection fraction right there. So that's already calculated for you now. So having said that, these three parameters, then you look at the incidental findings like AR. You're also looking at the mitral regurgitation and aortic regurgitation, depending upon whether it's mild or whether it is severe in category. And the way to look at and understand that is by briefly in this fashion. If you were to look at the left ventricle, I'll draw the outflow tract in this fashion. This is your this is just a schematic. So the blood flow is going via the mitral valve into the left ventricle, and as the left ventricle contracts, it sends blood up into the aortic valve and then up into the aorta. So as a result, what happens is when it is contracting in this fashion, obviously you're looking at some of the blood may actually regurgitate back, and when it regurgitates back, it is aortic regurgitation. This is AR. Okay, because in diastole what's happening is some of the blood is regurgitating back, and that will be represented in a different direction. Depending upon how far does it go to the apex, that will define whether it's 1+, 2+, 3+, or 4+. 4+ being the severe AR. Similarly, in the mitral regurgitation variety, if you were to do, you will see that when the ventricle is contracting and the mitral valves are incompetent, some of the blood will regurgitate back into the left atrium. Now we can draw the left atrium here if you like, and this is your LA. So depending upon how far does it go, the mitral regurgitation jet during the ventricle systole. Now remember, this is happening in systole, aortic regurgitation is happening in diastole. So during systole, as the blood is going into the left atrium where it should not go, okay, it should only go through the aorta up into the aortic arch and to the rest of the body. Some of the blood is escaping into the mitral valve, and that is depending upon how far it goes. 4+ will be the way to say that this is mitral regurgitation of a severe variety when it's on the top of the left atrium or the roof of the LA, I call it. And then it is somewhere here in the middle, it will be moderate AR, again empirically, and this will be mild AR when it's just sitting right across up to the mitral annulus, or a little bit, maybe a centimeter or two within the left atrium. Again, these are arbitrary ways of looking at mild, moderate, and severe MRs. Now, having defined that, then you also look at certain very important findings, which is the obviously you're interrogating the aortic valve, so you look at the aortic valve anatomy. Now when you look at the aortic valve anatomy, what you're looking at is whether there is any calcium in the valve. You're looking at if it is a bicuspid valve. Again, I'm writing in a hurry, so pardon my handwriting. And then third is the rheumatic variety. And the rheumatic variety will be also seen here. So now, what do you understand from that? Basically, what you're doing is you're drawing, as in a schematic form, the aortic annulus, where if you're looking at it from short axis, this is how the three leaflets will look like. But then when you were to look at a bicuspid valve, the bicuspid valve will look more or less like this. So you'll have two leaflets. Normally, we have aortic valve with three leaflets. As you know, it's a trileaflet. So bileaflet will be a bicuspid variety right here. And this is very prone for calcification, just so that you know. The calcification can occur anywhere along the lines here, and sometimes encroaching into the valve leaflets, so minimizing their mobility, sometimes making them very friable as well. And aortic, I call them calcium flakes, can fly out and actually give mini strokes or TIA. So you have to be very careful. That could be also an involvement there with the calcified aortic valves. Now, calcification is very, very common in bicuspid valves, as I said, but also occurs in tricuspid valves as well. The rheumatic process normally starts at the commissures here, whether it's in bicuspid or whether it's in tricuspid, doesn't really matter, and then encroaches into the central region, and this is where the aortic functional area will be compromised, and the aortic stenosis will result over a period of time. Again, rheumatic aortic stenosis does not happen with one simple attack of rheumatic fever. It takes ongoing several years or several months, sometimes, of inflammation and then scarring, and as a result, aortic stenosis will develop. So this is what you will see. You'll also like to calculate the aortic valve area. Now, that's normally calculated by continuity equation, which I have in detail actually discussed in my earlier segment number 266, if I can refer you to. So I'll refer you to video segment 266. If you can just go on MuniMeterHealth and type 266, it'll show up as continuity equation where aortic valve area is being calculated as well there in that setting. Okay, so having defined all these things, then you like to see if there's anything else that's present, including pulmonary pressures. So you like to see if there are any pulmonary pressures which have been elevated, called pulmonary hypertension. So these are incidental findings that you like to report, and of course measure the pulmonary pressures on the right ventricle side as well. Now, having defined all of this, then you look at how do you classify aortic stenosis, whether it's mild or whether it is severe, depending upon what the parameters are. Now, when you look at these mild, you'll see the jet velocity is one of the ways to really see that. What is the maximum velocity? So V max of the aortic valve at this level has to be measured, and the Vmax, and then you can look at that velocity. Say if the velocity is more than 4 meters per second, obviously, this is considered as severe aortic stenosis. Now, along with that, remember that you can compute that into a pressure gradient. So the pressure gradient P max here would be obviously 60 and above, and here the P max for mild will be more than 40 only. Now, if you were to look at the P mean would be about 20 or so. Here it'll be more than 40. And then you look at the ratio between the pressure gradient in the pressure gradient between the LVOT and the aorta. So you look at the LVOT and the aortic valve ratio. If you were to compare, here the ratio will be more than 0.5, and here it will be less than 0.25 in a severe variety. So these are the different ways by which you can look at the aortic valve while doing the echo examination in these patients, because this is what is required of you to really understand and actually quantitate the aortic stenosis, because now non-interventionally, echo is the gold standard to evaluate the aortic stenosis, and your surgeon, whoever you're referring to, will rely on your data that you're going to be referring over to. Now, on the board's exam, obviously they'll be asking you a great deal about what the ejection fraction normally should be before you send the person for surgery. Obviously, ejection fraction should be good. If it is too low, then those valves will not perform too well postoperatively or even intraoperative. So that's one of the things that you have to remember. Stroke volume is important, and you need to tell the surgeon if it's a calcified valve, if he's repairing it or she's repairing it. So it's very, very important. Also, you need to know how much was the severity, because obviously the severity has to be looked at first before the patient can be referred over. So severity, you look at all these parameters here and then decides whether these patients can go for surgery, etc. in this category. Okay, and pulmonary hypertension, sometimes if it is present, then that could be irreversible, and if it is irreversible, then that is not a case for aortic stenosis. So anyway, a lot of things that we can discuss during this segment, but the whole idea is wanting to tell you how the echo examination really is helpful for evaluating the aortic stenosis in our settings. Okay, so thank you again for staying tuned with MuniMeterHealth. If you like this segment, please push the like button, and of course I hope you're subscribed already, and bring all your friends, your colleagues, and your other students as well, who can learn with us on MuniMeterHealth, because we are a teaching channel only. We are not a medical advice channel, and if somebody's having an emergency, I suggest that please go and see the nearest doctor, the nearest hospital, and or dial 911 if you're in the United States to get to the hospital right away. Okay, so remember, it's an educational channel. We are promoting